All right, looks like we're going to get started here. Good afternoon, everyone. My name is John Danig with the University Hospitals Clinical Research Center. Thank you so much for joining us today for our Discover the UH webinar series, a monthly webinar series dedicated to exploring the intersection of healthcare, clinical research, and social justice, and shining the spotlight on research across the UH system and the great work that they're doing to advance science and medicine. This month, we are turning our focus to exploring heart and vascular health research and awareness. And we're actually really excited to be joined by two of our physician scientists today who will be talking with us a little bit about their work, their research, and a little bit more about themselves. But first of all, I would actually like to introduce to you Dr. Mehdi Shishabor, who was appointed president of University Hospitals Harrington Heart and Vascular Institute in 2020 after joining UH in 2017. Before joining UH, Dr. Shishabor directed the endovascular program at the Cleveland Clinic and trained over 40 interventional fellows and 400 physicians nationally on advanced techniques for limb salvage. In addition to his leadership roles, Dr. Shishabor is an internationally known interventional cardiologist and author of a number of editorials, textbook chapters, and is widely published in leading journals such as the Journal of American Medical Association, New England Journal of Medicine, and the Journal of American College of Cardiology and Circulation. Dr. Shishabor is an expert in minimally invasive approaches to reconstruct lower extremity arteries in order to treat critical limb ischemia and prevent amputation, which he'll actually be talking a little bit about later on. And his research interests include clinical outcomes in interventional cardiology, carotid and endovascular interventions, and has worked with a number of startup companies and early phase devices. Dr. Shishabor is also the Angela and James Hambrick Chair in Innovation and was recognized by University Hospitals in 2020 as Distinguished Physician for his commitment to patient care. He's an NIH scholar. He's won a number of awards by international and national organizations, and currently serves as a chair for Vascular Council for Society of Cardiovascular Angiography and Interventions, and is a writing member for guidelines for lower extremity peripheral artery disease. He's also an active board member with the Cleveland chapter of American Heart Association, where he is a voice for the community and proactively helps to provide solutions to a growing need. Please join me in welcoming Dr. Shishabor.
Thank you so much, John, for having me. Looking forward to having a good discussion today.
Absolutely. And our second panelist today is Dr. Nene Ukigwe. If I said that right again here. Dr. Ukigwe is an interventional cardiologist and member of the Valve and Structural Heart Disease Center at University Hospitals Harrington Heart and Vascular Institute, with a particular focus in the transcatheter valve interventions and percutaneous therapies for hypertrophic obstructive cardiomyopathy. A little bit of a mouthful right there. I'm glad I made it through that. Dr. Ukigwe earned her medical degree from University of Ibadan in Nigeria, where she also completed a surgery residency at the University College Hospital. She then completed an internal medicine residency at the Reading Health System in Pennsylvania and fellowships at Penn State University, Hershey Medical Center, Beth Israel Lahey Health Center in Burlington, Massachusetts, and Minneapolis Heart Institute and Abbott Northwestern Hospital in Minneapolis. She has special interest in hypertrophic cardiomyopathy, transcatheter therapies for aortic, mitral, and tricuspid valve diseases, and she has authored numerous publications and given presentations on these topics at local and national professional meetings. Everybody, please say hello to Dr. Ukigwe.
Hi, thank you very much. That was a generous introduction, and I'm very glad, happy to be here. Thanks for the invitation.
Absolutely. So we've actually asked our two guests today to talk with us about topics surrounding heart and vascular health that they feel should have a little bit more awareness, as well as some of the work and research they're proud of, and to shine some light on the great work that they and their teams are doing to help shape the future of heart and vascular health from right here in Cleveland, Ohio. But with that said, I'd like to pass the mic over to Dr. Shishabor. Dr. Shishabor, the floor is yours to share your screen and your presentation.
Well, thank you, John. Thank you so much for having us here today. This is a very special session, in my opinion, because as you nicely described, we're trying to kind of address the transaction between disparities, equity, and social equity, and science, research, and what we are passionate about, which is healthcare. So with that, I'd like to share with you a little bit about the work that we have been doing around limb salvage and preventing amputation. So let me share my screen with you here. And we will go here and go to the PowerPoint presentation. Okay, can you give me a thumbs up, Anene, if you can see my slides on the screen? Okay, well, fantastic. And I apologize for grossing you out at lunchtime because the kind of patients I treat usually present like this. And I'm sorry for those that have not seen these kind of pictures, but these are the kind of patients that come to me. And these are 6 patients that were at risk of losing their limb. They were at the risk of getting a major amputation. And we know that major amputation has significant implications. 50% of patients that lose their limb die within 2 years, 50%. And we know that losing a leg has significant social and emotional implications for our patients, not to mention their inability to be able to be functional members of the society from the standpoint of work and their quality of life. Now, unfortunately, in discussion about disparities and equity and social equity and medical equity, these patients are highly undertreated. So it turns out that in this a very nice study, when they looked at across the United States in different regions of vascular intensity care. So on the x-axis, we have very low intensity regions. So that would be an area where there is not much of vascular doctors. There is not hospitals that offer vascular care. Let's say in Midwest, in some areas that there are not much medical care. A high intensity region would be like Cleveland, where you have university hospitals, you have Cleveland Clinic, you have Metro Health, you have a number of providers that provide vascular care. And the authors looked at patients that had amputation. So all of the patients in this study had a prior major amputation, either below knee or above knee. And what the authors showed that in these patients, when they looked in the year prior to their amputation, even in the highest intensity regions, over 40% of the patients had no vascular workup or evaluation prior to their amputation. And that ranged between 70% to 40%, regardless of the region of where the patients lived from a standpoint of vascular care. So patients are getting their limb amputated, they are losing their leg, but they are not getting the vascular evaluation that they need. And that is very concerning. Now, I wanted to show you a case that I was involved with. This was a 68-year-old African-American man, a patient that was referred to me when I was in my previous institution. And this patient was evaluated for 2 years for congestive heart failure, which is the weakness of the heart. And as you can see, he had multiple other conditions. He had a prior open heart surgery, and he had valvular heart disease, had a prior heart attack, and so on and so forth. But the patient had these ulcers on his leg for 2 years. And unfortunately, because of the ulcers and extensive swelling on his legs, he had been wheelchair bound to the point that he was not walking anymore. And there were multiple notes in the chart saying that the patient was non-compliant, that the physicians had felt that these were venous ulcers. And for venous ulcers, we typically recommend that the patients elevate their leg to allow the swelling to go down so that the ulcers can heal. And they were saying that the patient is non-compliant and that for that reason, the patient has ulcers and is now unable to walk. And the patient was complaining of significant pain when he would elevate his leg. So 2 years, this was going on for 2 years. Eventually, somebody referred the patient to me actually for get advice about wound care, not so much about, vascular disease. And I ordered this test, which is a very simple test. It is a very nominal cost. There is no IVs required for this test. Basically, it's blood pressure cuffs that we put on the arms and the legs. And immediately when I saw this test, I was like, oh my God, this patient has significant vascular disease. And how could this have been missed for over 2 years? So based on that, we brought the patient to the cardiac catheterization laboratory to try to find out where the blockages were. And let me walk you through these pictures. Here on the left panel, you can see there's a needle that's going, that's the groin area. And we're trying to take an angiogram. And where you see that there is a gray area or the black area, that's where the artery is open. Where you see there is nothing, that means the artery is missing. That's on the left panel. On the right panel, we came in from the arms and we went down and we took a picture. And lo and behold, this patient had 100% blockage of the main artery, which we call the aorta, that supplies blood to both of our legs and to our pelvis. It was 100% blockage. I couldn't actually believe it, to be honest with you, because like I said in the chart, for 2 years, there were indications that this patient was non-compliant and that these were related to non-compliance. Fortunately, this is something that we can treat. So right there in the operating on the table in the cardiac catheterization laboratory, we were able to fix this patient's arteries within 2 hours and open the blood flow to his legs. Remember, and this was the blood flow the next day. The next day, the patient had significant blood flow. Remember the flat lines I showed you before, and look at the blood flow now. This is the way it should look, and this is the normal blood flow. And suddenly the patient became compliant. He no longer had pain when he elevated his legs, and he was able to get the swelling down, and you can see the wounds healed within a matter of weeks when these wounds were on for over 2 years. And again, we had to teach the patient how to walk because he hadn't walked for so many months because of his pain and suffering that he underwent. So because of cases like this, I was really passionate and motivated to try to address these issues. The fact that there are patients that are undertreated, the fact that there is a disparities in care if you are an African-American patient versus if you are a white patient. And we know that the patients that have vascular disease and are at risk of amputation are getting sicker. This is data that we published from 2003 to 2011. The risk of hypertension has increased, obesity has quadrupled in prevalence, diabetes has increased, chronic kidney disease has doubled, and patients are much more complicated now compared to 10 years ago, 20 years ago. Well, the disparities are very prevalent, and there are disparities in all kinds of areas. This is disparities, geographic disparities. For example, if you live in a tobacco belt, you are much more likely to get amputated than, let's say, if you live in South Florida or you live in the Northwest or in the Midwest. So there's a geographic disparity in amputation. We know that there is a gender disparity in acute limb ischemia. This is data that we published showing that there's a gender disparity in amputation. And this is a racial disparity. It turns out that if you are white and you present to a hospital compared to a Black patient who has the same clinical presentation, you are 4 times more likely to undergo revascularization if you are white, and you are 4 times more likely to undergo an amputation if you're Black. So if you're Black, you do not get revascularization, you don't get the right treatment, but yet you're 4 times more likely to get amputation. And this data was very concerning. So we said, what can we do here at UH? Is there a way that we can research this? Is there a way that we can get the community involved and we can address this? And one of the things that has always bothered me has been the heterogeneity of care in medicine. Medicine is no different than anything else that we do in life. For example, if any of you have ever painted your house, you know that not all painters are the same. Sometimes you get lucky, you get a person that's very professional and does a great job. Other times you may get somebody that does a terrible job, and then you have to hire somebody else to make the job correct. Or if you go to a mechanic, or if you go to a restaurant, not all restaurants are the same. Not all engineers are the same. But it turns out not all doctors are the same. And when you're dealing with complicated conditions like losing your leg, you need a group of experts. You need the best doctors to be taking care of you and making sure that you don't undergo an amputation. So we looked at UH and we said, well, what happens in our system? And it turns out that it's very complicated. we had 11 hospitals that provide vascular care at university hospitals under the Harrington Heart and Vascular Institute. Some of these hospitals are academic, some of them are community, and some of them are independent. We have a joint venture. We have a relationship with them, but they're not even completely UH. We have different providers that provide care for vascular patients. We had, at the time, we had 9 vascular surgeons, 4 interventional cardiologists, 5 vascular medicine. We had a number of podiatrists. Some of them were independent, some of them were UH. We had wound care specialists that were not podiatrists, and we had plastic surgeons that were part of this team. So it was a very heterogeneous group of patients. Some of these people are experts in limb salvage. Some of them are not. Some of them are extremely passionate about limb salvage. Some of them are not. And we know that limb salvage is a very complicated disease. As I've shown you here in this diagram, there are a number of people that need to be involved. These people need infectious control. They need their diabetes managed. They need their risk factors managed, and so on and so forth. So we said, well, how can we take out the heterogeneity of care? The other issue that is very important in this population is that a lot of these patients come from a lower socioeconomic class. And many patients have told me in the past that, doctor, my father had an amputation, my uncle had an amputation. This is what I expect. I figure one day I'm going to have an amputation. And many patients do not ask for a second or a third or a fourth opinion. And this is a fundamental issue in medicine and in conditions like this, where there is a huge disparity, because the patients that have the condition, they don't ask for a second or a third or a fourth opinion. So we said, well, what is the system that we use currently? How does it work? Well, it turns out that if you're a patient, you can enter our system in a multiple different ways. You can be seen by a podiatrist. You can be seen by an interventional cardiologist like myself. You can be seen by a vascular surgeon. You can be seen by a vascular medicine doctor. And each of these doctors can evaluate you and independently make a decision that, you know what, there is not much more we can do. You need an amputation. And this was the problem. We didn't want that decision to be independent. We wanted that decision to be made by a team, not just any team, a team of experts. So we wanted these folks to be able to see patients, take care of patients, treat patients. But when they decided they wanted to send the patient for amputation, there would be a stopgap. We wanted to stop it right here. You can't go to amputation until you're evaluated by a team of experts who are passionate about preventing amputation and that can work together to try to see if they can prevent amputation from happening. So we created in 2019, we created a Limb Salvage Advisory Council, Limb Salvage Advisory Council. And we placed this advisory council right here. We told our team, listen, do whatever you like to do. See the patients, treat them, take care of them. If you can save their limbs, great. But the minute you decide that you can save their limb, you better activate the Limb Salvage Advisory Council, because we have the experts waiting to hear from you before the patient goes to amputation. Now, if the council evaluated the patient and decided that amputation was correct, patient will underwent amputation. If the council decided no, the patient can be revascularized, meaning that we could improve the blood flow, the patient underwent blood flow restoration, and we tried to save the leg. And we followed these patients over time because we wanted to publish this work and educate ourselves, but others across the United States, because this program does not exist currently in the United States. And the way that the program worked was very simple. It required a lot of investment because, you can't run these programs without a coordinator. You need investment from the institution, from various philanthropic contribution to be able to run this kind of programs. So the way it worked is that when the patient was scheduled to undergo amputation, we had a coordinator at the time. Her name was Tanya. Tanya would get activated. You could reach her with different ways. And then Tanya would set up a meeting, like a board meeting or an LSAT meeting, which was virtual. You could be anywhere in the world. You could join the virtual Zoom meeting, just like right now, Some of you are maybe at home, some of you are at work, some of you maybe in a restaurant. You could just join in a Zoom meeting and the case will be presented. It will be evaluated by a group of experts, usually about 10 to 15 people, in a matter of 15 to 20 minutes. And then we made an action plan out of this review. And this is the work that we did, that we published, which we are very proud of. What we showed that here at university hospitals, amongst patients that were scheduled to undergo a major amputation, and I want to emphasize this, remember, these are patients that the team has done everything they can, and they have now said there is nothing more that can be offered. And these patients would have otherwise undergone a major amputation, that would have lost their leg. We were able to, in 95% of the cases, to offer revascularization to those patients. And of those patients, remember, these were patients that were told there are no option. 95% of them ended up having an option because of this program. And of those patients, 75% of them, we were able to save their limbs in 6 months follow-up. 75% of those patients that were scheduled to undergo a major amputation, we were able to save their limb. And this was a multidisciplinary group of interventional cardiologists, vascular surgeon, vascular medicine, wound care experts, plastic surgeons that work together to make this happen. Now, is there any opportunities? Can we make this better? It turns out that during the same time, there were a number of amputations that actually were not referred to the LSAC program, which I'm sad to say. And again, this goes back to the resources. Can we put more resources into these programs so that every single patient is considered under the Limb Salvage Advisory Council? Only 20 patients were referred to the Limb Salvage Advisory Council, but there were over 80 patients during that time that underwent amputation. Now, some of these are trauma, and there are patients that just were not appropriate, but I'm sure there were many more patients, even at UH, that we could have helped and saved their limbs. And there's ongoing research and effort to make sure that we take care of every patient that comes to us and is at risk of amputation. So the goal of the presentation was basically to showcase to you that we are very active here at University Hospital to address disparities in care in this particular situation, amputation. We are very eager and interested in taking care of these patients, not only in heart and vascular, but across all disciplines. That we believe research is extremely important, that we need patients from different backgrounds to be participating in research so that we know more. You know, just because something works for a particular population, it doesn't mean that it's going to work for all population. And it's extremely important that we have diversity from gender, race, ethnicity in our research and in our clinical trials. And that, you know, if there are people out there that can support these kind of initiatives, that they're willing to reach out to us and support this kind of research so that we can continue to impact healthcare and disparities in health. Thank you so much for this invitation.
Dr. Shishipour, thank you so much for your presentation. You're right, the images were a little bit jarring, but as jarring as some of those images were, I do think it's really important, like you were saying, to, illuminate the importance of a multimodal, multidisciplinary approach to, I guess, not only vascular and wound care, but also a layered approach to educating and including all different communities to hopefully reduce these disparities. So the research that you're doing in clinic, I would say, is equally as important as the research and the work you're doing out in the community to address these things. So thank you so much for that. Next, we invite Dr. Ukigwe to the floor. Dr. Ukigwe, the mic and screen share are yours.
Okay. Can you all see my screen?
We can see the screen, and I think all you have to do is launch the PowerPoint. Yeah, there you go.
Okay.
Oh, and we're looking at your notes right now.
And then if you can go to the display setting on the top left-hand corner.
Yeah, let me.
Display setting right on top of your slide. It says display, it says show taskbar, and then the next one it says display setting. right on top, right there. Yeah, click on that,
Yeah.
and then click the first one. Right.
Yeah. Thank you.
Thank you. Sir.
Perfect.
Thanks, everybody. It's truly a pleasure to be here. I'm going to go over a couple of the studies that we have on participating in within the hypertrophic cardiomyopathy group and the structural heart disease group. And the first, which I'm really passionate and I'm excited about, is hypertrophic cardiomyopathy. And basically, this refers to abnormal thickness in the heart muscle that is cannot be explained by things like hypertension or anything else, and is specifically a genetic disease. It is autosomal dominant, and it's popular because most people know about it because it's the commonest cause of sudden cardiac death in young adults, but no age is spared. It was actually first described in an older woman. Now, we used to think it would only happen in about 1 in 500 people, but now with advancements in cardiac imaging, with genetic testing, we know it's actually as common as 1 in 250 people. Now, the good news is that only about 30% of these people will need subspecialty procedures to try to address symptoms or improve mortality. It's a very heterogeneous disease, and the thickening of the heart muscle can occur in different ways. However, irrespective of how it happens, the end point is usually similar. People end up with heart failure symptoms. They could have abnormal heart rhythms that could increase the risk of stroke or result in sudden death. They have chest pain, and sometimes they could have mitral valve disease. And that clinically to the patient means they have shortness of breath, fatigue, syncope, shortness, atrial fibrillation, and again, sudden cardiac death. There was actually a study that I did not include here, there was a survey of people who had hypertrophic cardiomyopathy, and they found out that the questions were, from before you had hypertrophic cardiomyopathy, what did your healthcare providers use as an explanation for your symptoms? And a lot of people were told they had anxiety, asthma, mitral valve prolapse, depression. And it was actually found that those wrong diagnosis was more common in women. Now, the treatment options for when people have obstruction, meaning that the muscle is so thick and it contracts very vigorously so that blood flow can't get out of the heart. The traditional procedure was surgery, where you go and cut out the muscle that is contributing the most to that obstruction. Now, in 1990s, there was another procedure that avoided surgery, where you could go isolate the blood vessel to that area and basically block out that blood vessel, and in so doing, make that area, the shape of that thickened area, to change, and therefore improve blood flow out of the heart. But as early as last year, there was a recently approved medication that had been in clinical trials. And what this does is that it actually inhibits the parts, the fibers or the part of the muscle of the heart that causes contraction. And if it inhibits contraction and makes the heart not contract as vigorously, then the obstruction to flow out of the heart is going to be less. Now, here at university hospitals over the past 18 months, there has been a newly established hypertrophic cardiomyopathy board, which is, has led to exciting growth in this area within the institution. And it's a multidisciplinary team of cardiologists and cardiac surgeons, including geneticists who have special interest in hypertrophic cardiomyopathy. We meet twice a week, and it's been interesting. There's been an increase in referral to for these people. And we've all learned from each other, in addition to the fact that some people who have actually come to the board with diagnosis of hypertrophic cardiomyopathy, we found alternative diagnosis for them. And that again highlights what Dr. Shishaba was talking about, the importance of multidisciplinary care in cardiology. So the study that I was going to talk about here is a retrospective and prospective registry that is basically, we're proud to be part of in university hospitals. We're only one of about 50 sites that are participating in this. And it's basically to see, now that there's this new medical therapy for hypertrophic cardiomyopathy, what exactly happens in the real world. So if somebody comes to an institution with hypertrophic cardiomyopathy, how many people end up with medical therapy? How many people end up with either catheter-based interventions, which is what I do, or surgery? And what factors into picking those, and how do the people do long-term? This is supposed to be a follow-up out to 7 years, and we're excited to kind of shed more light in a more systematic way about what happens to people with hypertrophic cardiomyopathy and with obstruction, because there's several things that have not been answered yet. Does reducing obstruction, how much does it affect having abnormal heart rhythms? Does it even affect it at all? Those are some of the things that we're hoping that we can answer with this. Now, the next set of diseases I'm going to talk about will be valvular heart disease. Now, the concept of a heart valve team, which is a multidisciplinary team, fortunately has been inbred within the valvular heart disease space for some time, and is actually reflected in the guidelines. Now, the first condition that I'm going to talk about is mitral regurgitation. And this study basically highlights what we know. All of mitral regurgitation is bad. And this top panel highlights the fact that whenever people have mitral regurgitation, irrespective of if it's primary mitral regurgitation, which means that the valve has a problem, or secondary mitral regurgitation, which means that the muscle that the valve is attached to has a problem, mortality out to 1 year is pretty high. So like one in 5 people are going to die at 1 year if they have severe mitral regurgitation. And if you look at this lower panel, the older we are, the higher that mortality is. And what does this mean? That people who are, and we know that people who are older are less likely going to get treatment because of comorbidities and increased risk of operative interventions. And therefore, that's what led to transcatheter therapies, which are procedures where we can treat valve disease in the cardiac catheterization lab by going through a keyhole incision that's about the size of my pinky through their groin. And we can do these procedures to help treat mitral regurgitation. Now, when this was first approved, when the transcatheter technology was first approved, one of the Achilles heel of it was that there was an increased risk of having recurrence. However, industry has stepped up to the plate and change the technology. It's not just more deliverable, people are more familiar with it, and there's a wider range of sizes that people could use. And we see now that in the real world experience of this, that there is now, when you follow people out, you're more likely going to have a sustained reduction in mitral regurgitation, even when you do transcatheter therapies. So this is an example of a patient that I treated. And here, what we see in this yellow colored portion that is going backwards towards the right side of the screen is blood flowing backwards in the direction that it's not supposed to. And in the bottom panels, we can see where I'm highlighting here. These are the clips. This patient ended up with 3 clips, and we can see that the amount of blood that is flowing back towards the top chamber has significantly reduced. And this patient was able to leave the hospital the next day and actually went back to working on his farm, which he said he had been unable to do for about 4 months. Now, the trial that we have for this is we need to try to figure out now that we have better technology and ways of delivering this MitraClip therapy, can we extend this technology to patients who have leaky heart valve, severe mitral regurgitation, and are not high risk? So a 75-year-old man who is otherwise healthy, is it okay for us to do this procedure in these patients? Because this is not clearly supported by the guidelines right now. And that's where this trial is looking at people specifically with primary mitral regurgitation, because currently the standard of care for secondary mitral regurgitation is MitraClip. However, if you have primary mitral regurgitation, which is a problem with the leaflets alone, we're trying to see if you get clip and you are eligible for both the clip and surgery. If we randomize people to either one of those and follow them out, is there any difference with respect to mortality and repeat interventions. And we've recruited at least screened several people for this, and we'll be happy to have more people help us participate in this clinical trial. Now, as with surgery, not everybody can be repaired. Repair is the gold standard for primary mitral regurgitation. And if you cannot be repaired with surgery, you have a replacement. And right now in the United States, there's no FDA approved or commercially available replacement technology for native mitral valves. That's the one we're born with. And we're happy to, or we're lucky to also be participating in this clinical trial. Dr. Atizani is actually the principal investigator and a sub-investigator. And we're looking for people who have severe mitral regurgitation who cannot be treated with the clip, which is what's commercially available. And we go from incision again, we'll go through an incision in the groin. This time the incision is slightly bigger, and go to replace the valve completely. So this is an example of a patient who had a leaky heart valve, again, the color that is flowing backwards. And when you have this cleft, you can't clip it because it doesn't, the way you position clips, you can't turn the clips around to make the leak from that area go away. So the patient should have either an open repair where you can sew it down, or you need to have a replacement. And so this technology we have, we've done in this institution, there's been several that have been done, but more recently we just is the first one from the groin. And here you could go from the groin and essentially replace that valve that I just showed you that is completely leaky. Is done with just X-ray and echocardiogram guidance, and people wake up, and the patient that we had was discharged actually the next couple of days and was back to his regular activities within a week. Now, the final valvular condition that I'd like to talk about here is moderate aortic stenosis. We've conquered severe aortic stenosis. Everybody knows that, or most people know that severe aortic stenosis should have surgery or transcatheter aortic valve replacement. And transcatheter aortic valve replacement is actually now the predominant way for valve replacements to happen in the United States. But now, what about people with moderate aortic stenosis? The current standard of care is that those people continue with medical therapy and they continue to be followed until they progress to severe. However, there's emerging data that that's actually not benign, and that people who have symptoms of heart failure and have, even if it's just moderate aortic stenosis from this bottom panel, we see that their survival is significantly impaired. And so the question is, we have a very safe technology of transcatheter aortic valve replacements. Is there any benefit to treating these people earlier so that we can improve, or are we going to affect the survival curve if we treat people earlier? And again, this is another study within the valvular heart disease team, and it's a randomized control trial, and we're taking people who have moderate aortic stenosis and no other explanation for their symptoms, and randomizing them to the standard of care, which is medical therapy and transcatheter aortic valve replacement. And we're trying to see if we improve their quality of life, their survival, and also do we trade anything off with increased risk with stroke, kidney injury, wound infection by doing a procedure sooner rather than later? I think these were all the things that I wanted to share about what we're doing in the valvular heart disease team, and I will take any questions now. Thank you.
All right, Dr. Okigwe, thank you so much for this. Going back to some of your more earlier slides, some of the conversation we've having, I think a lot of people hear about the benefits of cancer tumor boards out there. So I'm really encouraged to see that the hypertrophic cardiomyopathy board is really generating new pathways and care and the diagnoses that otherwise, could not be seen. I, for one, didn't really know that that sort of board existed. So thank you for enlightening me on that. But for everyone here in attendance, you can see, Dr. Shishabor, Dr. Ukigwe's work is really a prime example of the prowess UH has in medical and scientific excellence, which really do contribute to our rich 150-year history of research and innovation. We've mentioned that time and time again. We'd like to continue with that trend with some of the work we're seeing throughout this series. But it looks like both of you are back on video now, which is great because we're gonna want to get to know a little bit more about you guys, your work through a Q&A session here. Some of your thoughts on research topics that you've discussed, access and health inequities in your fields, medicine in general. Also, if there's anybody in attendance who has a question, go ahead and please feel free to type those into the Q&A module at the bottom of your screen. But the first question I have for both of you here, now let me make sure everybody can see each of you. Now you both talked through a lot of medical breakthroughs and discoveries that you've had, but one first has to become involved in research in order to kind of find those. So the first question I have for you both is really what led you to become involved in clinical research and why is it important in your specialty? Dr. Shishabor, would you like to go first?
Sure. For me, research is hope, and that's why I became a doctor. And it is only with research that we can advance our field forward, and more importantly, be able to provide hope and take care of patients that have no hope. And that's what I love about, our ability here at UH to be able to be at the cutting edge, bring novel, new research. There are every week, honestly, there's a project that we take on that we are the only hospital in Northeast Ohio, the only hospital in the state of Ohio, or one of 5 hospitals in the United States offering a novel technology, new technology. As you know, research also is not free. There's a lot of cost associated with research, and in many cases, we may even, have to invest as an organization in being able to do some of this cutting research so that, the population here in Northeast Ohio have the availability of cutting edge technology and research for some of the conditions that are out there. So for me, it's hope, and that's why I'm involved with research.
Hope is important. A lot of people thrive on hope out there. So I appreciate your answer there. What about you, Dr. Ukigwe?
So I think the thing is, the evolution of medicine from as far back as, when we still use phlebotomy to treat everything to what we have today could only have happened because of research, right? It's not just about the day-to-day care of individual patients, but like the power of that observation, inquiry, trying to figure out how to make things better is what has led us to where we are today. And I think that it behooves us to continue to, find clinical problems and, make things better for our patients on a day-to-day basis, but also try to improve the practice of medicine for the future generations. And I think that being able to contribute in some parts in that way, not just in, finding better ways of doing things, but also finding new technology, finding ways to reach people who need technology that shouldn't get it. I think everybody has a role in some parts with research to overall in different facets of care, different facets of the care that we deliver, advance the care that our patients receive.
And then there was a question in chat, somebody, and I messed it up. I was trying to answer it for you, but I messed it up. Somebody is asking if one of their family members has hypertrophic cardiomyopathy, how can they get a hold of you, or who should they call?
Okay, I can type the answer, or I can answer that. Okay.
Yep, do it both. Why don't you answer it both ways? Can you do it verbally and also type it?
Okay. So right now, the way to access care from somebody who has, or any of the experts who have hypertrophic cardiomyopathy is multiple ways. You can have your primary care doctor refer you to us. You can access UH Care Connect and ask to be seen by a doctor who takes care of hypertrophic cardiomyopathy. And but I think the fastest thing that I can do for you, if you have somebody right now, is to text you my number, and then you can call my office and I'll get you set up.
Thanks so much for that.
Mhm.
It's always nice to know how to access, it's one thing to know that they exist, it's one thing to know how to access the care. So I appreciate that. I do want to ask you a couple of questions about some of the research that you talked about today, some of the other research. Dr. Ukiwe, this one is first of all for you, but you mentioned as part of your presentation that age is a factor. So as we age, are there any ways we can hope to reduce the risk of hypertrophic cardiomyopathy or even mitral regurgitation? Anything that we can do in daily life?
Yeah, so that's an excellent question. So hypertrophic cardiomyopathy, I'll start with that one. It's due to a genetic condition. So you're born with the gene that makes your heart develop that way, right? Now, the things that we can do to improve our symptoms and improve our survival are to take care of our overall health. The things that we can control. We can't control that gene, but we can control all those other parts. And the second part is to engage with the hypertrophic cardiomyopathy specialist, because the way that people with the abnormal gene that have hypertrophic cardiomyopathy presents it's a wide spectrum, right? And some people may present more with abnormal heart rhythms. Some people may present more with the obstruction. Some people may present more with valvular problems. And engaging with someone who is a specialist in that area. And we're lucky to have a center, or we have a group here that specializes and has interest in this. That's going to be one of the key steps to then tailor therapy. And that's actually what's reflected in the guidelines, that the care of people with hypertrophic cardiomyopathy should be shared decision-making, because it's never a one-size-fits-all. But also a key part of that is to take care of the rest of our health, make sure that we stay active, we have maintain a normal BMI, take care of high blood pressure, diabetes, all the other things that can compound heart problems, and then individually take care of the hypertrophic cardiomyopathy.
I see.
Then with respect to mitral regurgitation,
Mhm.
part of mitral regurgitation, again, is due to abnormalities in the valve itself, and that you can't do much about. However, most of mitral regurgitation in the United States and worldwide is actually because of abnormalities in the heart muscle that the mitral valve is attached to. And so a key component of taking care of mitral regurgitation is actually trying to prevent overall heart disease, which is taking care of high blood pressure, diabetes, maintaining good heart health, no tobacco, the standard preventive things that we all, do and have, should do the best that we can. That's what protects us for the downing, as we age.
Gotcha. So one's all boiled down to trying to lead as healthy of a lifestyle as you possibly can to reduce those risk factors. Couldn't
100%.
couldn't have said it as simply as that. Thank you for that. Now, speaking a little bit more on risk factors, again, Dr. Shishabor, this question's for you. So we've seen that high blood pressure and diabetes are two risk factors that are associated with PAD and CLI. So diabetes can be associated with foot ulcers and neuropathy. Do either of these symptoms have any additional impact on CLI, and would this have any additional complications for revascularization?
Wonderful question, John. And turns out that 80% to 85% of the patients I treat for ulcers and gangrene and patients at risk of amputation have diabetes. And almost 100% of them have hypertension. As you know, unfortunately, these conditions, these risk factors, they go together, right? And many of these patients, if not all of them, have hyperlipidemia, meaning high cholesterol. So there is a significant implication. So one is that we need to be very vigilant and identify, early on when these patients have an ulcer or a wound, so that these wounds don't progress and become more advanced. The more advanced they are, the less likely that we can save majority of the leg, right? So if somebody comes and the whole forefoot, the whole foot is gangrene, then we can save it, right? So it's very important that patients come early and get early advice. So that's one. Second is that the treatment for these conditions require very aggressive management of the risk factors. That means blood pressure needs to be well controlled. There has to be no smoking. You have to control the cholesterol. And importantly, you need to control diabetes. On top of all of these things, patients with diabetes have microvascular disease, So when we work, Dr. Ikugwe and myself, we work on macrovascular. So big arteries that we can put a stents in them, we can put a balloon inside of them, and we can treat them. The little small arteries, unfortunately, we cannot get into them because they're too small. So the way you treat those is with cholesterol medication, controlling your diabetes, not smoking, and so on and so forth. So yes, it is extremely important that we treat these conditions, both that there is awareness, that there is prevention, and then importantly, once people have disease, meaning that they have ulcer or gangrene or they have coronary artery disease, that we are managing these risk factors very aggressively.
Well said. Thank you for that. Now, another question. This has to do with both of you here. We're about 3 years out from the beginning of the pandemic at this point, right? So a study a lot of us have heard about is focusing on long COVID. Have you seen any sort of correlation between heart and vascular health with either acute or long COVID? Dr. Shishapur, would you like to address that one first?
Sure, happy to. Yes, definitely my field. I don't know how much of it Anen is dealing with, but there is a lot of vascular complications. I'm sure you may have heard the blue toe syndrome or blue toes, COVID blue toes or COVID toes. We also have seen that patients with COVID have a hypercoagulable state. That means that their blood clots, and those clots can travel, unfortunately, to the lungs. So we had, in the last 2 to 3 years, we have seen, and some of the vaccines, unfortunately, had some association with this. Not very high, very, very small numbers, but still, there were some, I don't want anybody to be afraid of the vaccine. So obviously, there's a lot more benefit than risk, but everything has risk. So, to your point, yes, there has been significant implications from COVID in the vascular field, both from the standpoint of blood clots in the legs and in the lungs, and also from some of the manifestation of COVID related to like blue toes and so on and so forth. And we continue to follow these patients. As a matter of fact, I just saw a patient last week with a blue toe related to COVID.
Wow. Dr. Ukigwe, anything to add to that?
Specifically, in addition to what Dr. Shishapur said, there's an associated increased risk of having acute myocardial infarction with COVID, the same way blood clots form in different blood vessels, it can form the arteries to the heart. And if people have blood clots in the arteries to the heart and the artery is blocked and not reopened, then the heart muscle suffers. And when the heart muscle suffers, then people are more likely going to, over time, develop mitral regurgitation, for instance. The other things that are reported in long COVID is chronic inflammation of the heart muscle, which cause myocarditis, and some degree of myocarditis can decrease the pumping function of the heart. And when the pumping function of the heart is decreased, because the mitral valve is attached to it, that mitral valve will not work properly, and therefore people can have mitral valve disease. But it's not something that tends to happen right away. That is a much longer term sequelae that we don't know, how much that is, or if people with long COVID are going to behave any differently than what we know that happens to people with other kinds of heart disease. And I think that's one of the things that time is going to tell.
A lot more to learn in that realm. It seems like, with all the different conditions that could arise from long COVID. So let's jump into, with about 5 minutes we have left, I want to ask a couple questions in general. Some of the things we've touched on a little bit. Dr. Ukigwe, this one's for you because Dr. Shishapur touched on this already, but one of the things we've been talking about recently is equitable ethnic and racial representation research study participation. Would you be able to talk a little bit about diversity and representation in research and why it's important to have it on both sides, not only just participants, but having representation on the researcher side as well?
So thank you. That's I'm glad that we're talking about that. So that's something that has plagued us, and by us I mean in medical community, for a long time. And some of that, as Dr. Shishapur touched on, maybe due to access to care, and it's most likely multifactorial. However, when we have clinical trials for new devices, drugs, it's best if those tested in the population that you intend to treat. And what we found out is that there's a certain demographic that keeps participating in clinical trials. And by demographic, I mean, it tends to be Caucasian males, which may have to do with access, but the population has diversified a lot more since then. And we know, from at least if we start from some of the heart failure trials, that some medications may not work the same, there are racial differences in the way medications work. That's just one aspect. The other part is the gender-based portion of it. And we're recently starting to incorporate that into, our and by our, I mean cardiology guidelines, for instance. Like, women are not little men. We have different presentations for cardiovascular disease. We have different outcomes for the exact same cardiovascular disease, and trying to learn and unearth that instead of just taking results and devices from clinical trials that were done in predominantly men and just putting that in women and expecting the exact same outcome is not going to be correct. Now, one of the ways that that's being addressed, like you touched upon, is also diversifying the investigators and people who participate in research, including the coordinators. And across board, when that is, more uniformly or more universally adapted, I believe that people are more likely going to participate in clinical research if they see people that look like them and they trust that they're not, one of the commonest things you hear is like, I don't want to be a guinea pig. If they trust that that's not what's going to happen, then they're more likely going to participate, and we can get, a more wholesome idea of how these devices work across different populations.
Thank you so much for that. And with a couple minutes left, I just have a really blanket question here for any patients or potential participants who might be online here. A lot of stigmas around clinical research, obviously here, but what are, for each of you guys, what are some of the reasons you may encourage a patient of yours to consider or participate in a clinical research study? Dr. Shishabor?
Well, I think that if you are interested in advancing science, if you want to contribute in providing hope to others, if you believe that the current science is helping you and you want to give back, if you want to make sure that the patients like you are getting the right treatment, going back to Dr. Ikugwe's point, if we don't have females, if we don't have other ethnicities and racial entities involved in research, we are basically treating them blindly. Just because something works for, let's say, Asian Americans or Asians doesn't mean it's going to work for whites or for African Americans or for others. Just because it works for men, it doesn't mean it works for women. So if you're a woman and you want to advance science, please, and you want to make sure that people like you and others like you are getting the right treatment, please get involved with research. Those are some of my thoughts.
Awesome. And Dr. Ikigwe, why would you encourage some of your patients to participate?
Again, I think, the reason to do that is, again, that everybody wants to do good. Like, everyone wants to leave like some degree of positive impact. And this is one way of doing it. And the care or the luxuries or the excellent outcomes that we enjoy now is because of the sacrifices or research or participation that other people have done ahead of us. And we've advanced so much that we're very vigilant about we're ethical about it. We're very vigilant about watching adverse events. And so if there's a chance for anyone to participate in a study that helps shed more light on the best way to treat a specific condition, not just for themselves, but for their family members, for future generations, then I think that having an opportunity to do that, or being in a position to do that and, offer that, I think it's not just, it's a privilege, and people should actually consider it.
Well said, and we'll leave it right there as we're at time now. But I just want to thank you both again for joining us today, Dr. Shishabor, Dr. Ukigwe. This has been very enlightening for a lot of people, and I'm sure a lot of people who will watch the recording of this afterwards will get a lot of benefit from this as well. But thank you so much again, everybody in attendance. Thanks for tuning in today. Please join us next month when we take a look at nutrition research to kind of go along with the trend we're going for healthier lifestyles. But until then, thank you again, and we'll see you next time. Take care. Bye-bye.
Thank you.
Thank you.